Hello, everyone. Welcome back to Science in the Age of COVID-19. As always, we are glad to have everyone with us here today. Well, we wanted to share something with you all before we head into the talk. Our first talk in this series was on April 16th, 2020, and we hosted Professor Britt Glansinger from HHMI UC Berkeley. So the series has been on air for 1 year. So at this time, we would like to pause for a second and say a huge thanks to all our speakers who, apart from doing this spectacular research during these testing times, have been very generous with their time to come and talk to us. Thanks also to you all, our audience, because your participation keeps us going. And a huge thanks to the Janelia team for making this happen. So on that note of thanks, let's head right into the talk today. So at this time, we are in the middle of a massive vaccine rollout all over the world, which is very impressive and exciting. But then we also have a lot of questions around these vaccines. For example, is it safe to get vaccinated when you're pregnant? Is it safe to get vaccinated as a lactating mom? Do these vaccines affect one's fertility? Well, so many questions, and all these are very important questions. So to answer these questions, we have an expert with us here today. It gives us immense pleasure to host Dr. Victoria Mail, who is a reproductive immunologist, joining us today from the Imperial College London. And as you can imagine, being an immunologist working on pregnancy, Vicky is perhaps the best person to answer all these questions and talk to us about on this topic. So Vicky, first of all, thanks for your time. Thanks for joining us today, and we look forward to your talk.
Hello, and thanks for inviting me to speak today. My name is Vicky Mail, and I'm a lecturer in reproductive immunology at Imperial College London. And that means that I'm particularly interested in the immune system in pregnancy. And today I'm going to talk about what happens when someone catches SARS-CoV-2 or COVID during pregnancy, why we might choose to vaccinate pregnant people against SARS-CoV-2. And I'll talk a little bit about the effects of COVID vaccination on fertility. Now, just in case anyone doesn't catch the whole talk, I'll say now that we have lots of evidence that there are no effects on fertility. And I'm also going to tell you a little bit about what happens when we vaccinate people who are breastfeeding. Now, I understand that we've got some non-scientists joining us today, so I'm going to try and make this as accessible as possible, perhaps sometimes at the expense of precision. And for the scientists, I apologize if we're at the expense of precision. But for most of this, I'm going to be relying on data submitted to the regulatory bodies by the companies that develop the vaccines, and on safety data that's been collected by the CDC in the USA, the MHRA in the UK, and the EMA in the EU. And I'm not really going to show you any data that's come from my own lab. But nonetheless, I would like to mention them. We're particularly interested in immune cells in the lining of the uterus and how they affect the success of pregnancy. So Yvonne is looking at how NK cells in the uterus impact placentation during early pregnancy. Emily is looking at how those same cells may be involved in the initiation of labor. Antonia is interested in a subset of innate lymphoid cells called ILC3, and Ellie has a project looking at how uterine NK cells develop using a mouse model. They're a really great team, and I couldn't spend all the time that I have been spending looking into vaccine safety if they weren't so supportive. So I want to give them a shout out before we begin. But before we talk about COVID-19 vaccination in pregnancy, let's talk about why we vaccinate pregnant people in general. You may know that pregnant people are routinely offered the Tdap vaccine. So the idea with that is that the mother raises antibodies that then cross the placenta and give the baby some protection in the weeks before it's able to get its own vaccine. In the USA and the UK, pertussis or whooping cough is the main concern here. But in places where sanitation isn't good, neonatal tetanus infection is also a problem. So the vaccine protects against that too. The other vaccine that is routinely offered during pregnancy is the flu vaccine, and that's specifically to protect the mother, although there are some side benefits to the baby as well. And the reason that we give that vaccine is because pregnant people are just more likely to die of flu than non-pregnant people. Now, one question we might ask ourselves is, why are pregnant people so much more susceptible to the flu? And often you'll see statements like this: when you're pregnant, your body naturally weakens your immune system to ensure the pregnancy is successful. This is an intuitively appealing idea, but it turns out not to be true. And I actually give an entire hour's lecture to our master's students on why it's not true. Don't worry, I'm not going to do that to you today. But to summarize, the idea actually comes from Peter Medawar. Now, most immunologists know him for his Nobel Prize winning work on tolerance in the context of skin grafting, which led to our ability to transplant organs. But he's also very important for reproductive immunology because of a paper, this paper, that he wrote in 1953. And in this paper, he noted that the immune system allows the fetus to survive during pregnancy, whereas if that baby grew up and tried to donate an organ to its mother, the organ would be rejected. So Medawar said, well, what's special about pregnancy that prevents rejection from occurring, rejection of the fetus? And he came up with 3 ideas. One of which is this idea that the maternal immune system is suppressed during pregnancy. Now, this was perhaps not an unreasonable suggestion in the 1950s, because then we didn't really know what immunosuppression looked like. But later, as we started to develop protocols to immunosuppress transplant patients so that they wouldn't reject their transplanted organs, and then in the 1980s, when we started to see AIDS patients, it became very clear that pregnant women don't really look at all like these people who are really immunosuppressed. And these cohorts of people actually allowed us to say that immunosuppression isn't helpful for pregnancy. So, for example, if we look at kidney transplant recipients who are immunosuppressed to allow them not to reject their kidney, we can see that 34% of them, when they become pregnant, get pre-eclampsia, and that's compared to 3 to 5% in the general population. 77% of them give birth prematurely, compared to about 10% in the general population. And 55% of the babies have low birth weight, compared to 10% in the general population. So immunosuppression is a bad thing for pregnancy. And in another situation where the immune system is somewhat suppressed, HIV infection, we also see an increased risk of preterm birth, low birth weight, and stillbirth. Now, obviously, both of these cohorts are immunosuppressed for a reason to do with their disease states, and so that might confound our analysis. But I think it is interesting to note that in the 2 main situations in which we see immunosuppression, we get worse outcomes in pregnancy. But more than that, we can actually say that certain aspects of the immune response get stronger and not weaker during pregnancy. And so for this reason, we see women with some autoimmune diseases finding that their disease gets worse during pregnancy. Examples of this are lupus, myasthenia gravis, and Graves' disease. And some autoimmune diseases, like MS, will get better during pregnancy. And what we are actually seeing there, the reason we see that getting better of some diseases and getting worse of other diseases, is because we're having a shift away from what we call a Th1, or sometimes it's called a type 1 immune response. And those are immune responses that are mediated by cells and that we usually use to respond to viruses. And we shift away from that Th1 response and towards what's called a Th2 response. And Th2 responses are good for making antibodies and responding to extracellular pathogens, particularly parasitic worms.
Hi, Vicky.
Hi.
I hate to interrupt. Are your slides supposed to be advancing? We're still seeing Medawar.
You're still seeing Medawar. Yes, Medawar is still there. I'm going to move away from him shortly. This is by way of background.
Okay, thank you.
Sorry, and we're moving more towards this immune response called a Th2 response that is good for responding to worms. And we have a lot of evidence that actually this shift isn't required for the success of pregnancy. So why does it happen? Well, could just be an epiphenomenon, but I personally wonder if it's not actually adaptive. Maybe because pregnancy is a bad time to have a high worm burden. You're already diverting a lot of nutrients to the baby, so worms on top is just too much. Or maybe it's to promote antibody production, since, as I've already mentioned in the context of the Tdap vaccination and a little bit in the context of the flu vaccination, antibodies can cross the placenta and provide some protection to the baby. So we know that the immune system is altered in pregnancy, not weaker, but altered. And since it shifts away from Th1, which is the specialist kind of immune response for dealing with viruses, it is perhaps less good at dealing with viruses. And we know that pregnant people are much more likely to die of the flu. And this is partly due to the altered immune response. But it's also to do with the fact that both flu and pregnancy put strain on heart and the lungs. So this also has something to do with it. So when the pandemic started, it was reasonable to suspect that something similar might happen with SARS-CoV-2 or COVID-19. And in the UK, for this reason, the government told all the pregnant people to stay at home a week before they locked down the rest of the country. But now we have more data on how pregnant people respond to SARS-CoV-2. So let's take a look at that. And to address this, I'm going to rely quite heavily on this really excellent living systematic review from the BMJ, which I really like because it's beautifully written and regularly updated. And the first thing that it finds is that when you do widespread screening, so you're not just looking at people who are symptomatic, pregnant people are actually more likely to be wandering around asymptomatic. And we had some really striking data to that effect from New York last spring, because they started screening everyone who showed up to give birth at Mount Sinai Hospital, so that they could, well, basically put the COVID positive people in one place and the COVID negative people in another place to avoid infections. And they found that 37% of these people who were showing up were SARS-CoV-2 positive. Remember, this is at the height of the epidemic last spring, the pandemic last spring, rather. But 72% of those positive patients were completely asymptomatic. And this systematic review confirms that high prevalence of asymptomatic infection in pregnant people is a widespread phenomenon. One that I suspect is immune mediated, because we know that a lot of the pathology in COVID is immunopathology. So maybe this shift from Th1 to Th2 might be able to reduce that somewhat. So that's good news, but it's not all good news, because by the time we start to look at people who are symptomatic, we find that pregnant people are more likely to need intensive care, more likely to need invasive ventilation, and more likely to need ECMO compared to COVIDs of the same age, sex, and various other characteristics like BMI who are not pregnant. Now, to be clear, though this is obviously bad, we're looking at twofold changes, roughly speaking, in the odds ratios. So it's still not as bad as flu. Although, of course, at the moment, you're far more likely to catch COVID than you are to get flu. So I don't wish to downplay the risks of COVID. Finally, if we compare pregnant people with COVID to pregnant people without COVID, they're more likely to deliver their baby early. And that's actually because their care teams opt to deliver the baby early, rather than because there's an increase in spontaneous preterm labour. Some reports have shown an increase in spontaneous preterm labour, but that's not something that seems to be kind of borne out by these widespread systematic reviews. And although the systematic review doesn't say this, the experience of my clinical colleagues is that they were opting to deliver babies early because they felt that by doing that, they could take some of the strain off the hearts and lungs of the mothers, giving them a better chance when they were very ill of surviving. But even so, pregnant people with COVID are more likely to die than pregnant people without COVID, and their babies are more likely to need intensive care. Now, we've already seen that most pregnant people do perhaps seem to be somewhat protected from COVID, and I think that that phenomenon is probably immune mediated. So I think that these, bad outcomes that we see in symptomatic people are likely actually to be due to the increased strain that pregnancy puts on the heart and lungs rather than an immune effect. But this is something that is still very much being formally investigated. But all of this is in people who are quite far along in their pregnancies. We're looking at people really in the second half of their pregnancies here. So another important question that we might want to ask is, do we see any effect in early pregnancy? perhaps an increase in miscarriages. And this is actually really difficult to tackle. It's so difficult that the systematic review specifically identifies it as an important question and says that there's not enough evidence to tackle it. And that's partly because miscarriages are really common anyway. The statistic that we usually quote is about a quarter of pregnancies end in miscarriage. So it's very common. And we also have this problem that if pregnant people tend to be asymptomatic, unless you're doing routine screening, you can't even know who did and didn't have the risk factor of SARS-CoV-2 infection. So this is difficult, but nevertheless, 2 studies have had a go at tackling this. This one is a case control study with 100 people who had a miscarriage paired with 125 people with ongoing pregnancies, matched for how many weeks pregnant they were. And they screened all of them and found that they were about 10% positive for SARS-CoV-2, whether they were in the miscarriage group or the ongoing pregnancy group. And there was also no difference in the proportion of people who had symptoms in each group. So that's suggesting that there's no association of SARS-CoV-2 infection or COVID-19 with pregnancy loss. This paper took a retrospective cohort approach. So basically seeing if miscarriage rates differed between the period in 2020, when SARS-CoV-2 was very widespread, compared to the rates in the equivalent period in the spring of 2019. And they weren't. So there's not loads of evidence, but we think that SARS-CoV-2 infection is not associated with miscarriage. But one thing that I think will be worth keeping an eye on, and I know that there are studies that are doing this, is whether we see an increase in birth defects in babies whose mothers caught COVID in the first trimester. And this is just because we know that there's an association between fever and certain birth defects, and we know that fever happens in COVID infection. So I think it will be worth checking on that. And finally, I want to say a word about whether, or a couple of words, I guess, about whether SARS-CoV-2 can infect the placenta, whether it can cross the placenta, and whether it can cause placental pathology. So in terms of placental pathology, there have actually been a lot of reports of placental pathology associated with SARS-CoV-2 infection. But the problem is that most of them didn't have a control group of placentas from uninfected people. And some of those that didn't blind the pathologist to which were infected and which were coming from infected mothers and which were coming from uninfected mothers. So looking only at the studies that had a normal control group where the pathologist was blinded. Here I'm showing blue as there was no difference between infected and uninfected mothers. Red is an increase in the pathology, and white is that the study didn't look. So we see that COVID infection, SARS-CoV-2 infection, isn't associated with chorioamnionitis, and that's inflammation of the placenta and the membranes around the baby. So we don't see inflammation there associated with SARS-CoV-2 infection. We also don't see what's called maternal vascular malperfusion, and that's a reduction in the blood supply coming into the placenta from the mother's side. But what we do see in some cases fetal vascular malperfusion, which is to say not enough blood coming in from the baby's side. But what we see most consistently is an increase in fibrin deposition in the intervillous space. The intervillous space is the space in between the villi of the placenta. That's the sort of fingers of the placenta that reach very beautifully, actually, if you ever look at it, up into the maternal blood. So we see an increase of fibrin deposition in between those. And some studies also saw an increase in thrombosis. So basically, and kind of in line with the vascular pathologies that we see in other organs in non-pregnant people, there is in SARS-CoV-2 infection an increased tendency to clot. So there are some changes in the placenta during COVID, but actually the ones that we're seeing are perhaps just the ones that we would expect to see based on the changes we see in other organs. And to be clear, these studies were seeing these pathologies more often in COVID cases, but they weren't necessarily seeing the pathology in every case. So finally, what about placental infection and vertical transmission to the fetus? Well, this is a graph from a systematic review that identified 936 SARS-CoV-2 positive women giving birth, and it looked to see if their babies were also SARS-CoV-2 positive. And by nasal swab, we can see that the babies were also SARS-CoV-2 positive in about 3% of cases. But that doesn't actually tell us if we've had a vertical infection during pregnancy, because those babies could have been infected in the ordinary way shortly after birth. But of the 26 placentae that were included in this study, 2 did show evidence of placental infection. So that does happen. And sometimes the virus crosses the placenta, because we can see it in cord blood in 1 out of 34 cases. And in 3 out of 82 cases, we can see anti-spike IgM in the baby when it's born. Now, for those of you who are not immunologists, I'll explain a little bit about this. We have 5 different kinds of antibodies, and the 3 that I'm going to talk about today are IgM, IgG, and IgA. IgM is the first antibody to be made during an immune response. And as the immune response goes on and the antibody gets better, it will usually switch to being IgG. IgA is the special antibody that coats mucosal surfaces, so it's really good at protecting you at your nose, mouth, and gut. And the only kind of antibody that crosses the placenta is IgG. So when we see IgM in a baby, we know that that's not antibody that's been transferred from the mother. We know that that's antibody that the baby must have made itself. And that tells us that the baby has been infected. So where we have looked at IgM, which tells us that, we've got an ongoing infection, we've been able to see that in 3 out of 82 cases. So babies can get SARS-CoV-2 from their mothers, sometimes even in utero, although it's worth saying that most babies who catch SARS-CoV-2 from their mothers will be just fine in the end. So from all this, we might think that we should take special care to protect pregnant people from COVID. And luckily, we now have vaccines that are safe and effective, certainly in the non-pregnant population. So a simple solution might be to prioritize pregnant people for vaccination, which is what you're doing in almost every state now of the United States. I think there are 7 that aren't, but 43 therefore, I guess, states are doing this. Or what you might at least do is offer them the vaccination if they're at high risk, which is our approach in the UK and in many countries of Europe. We're offering the vaccine to people who are at high risk because they're healthcare workers, or high risk because they have pre-existing conditions. Some other countries in Europe are saying we'll only offer it to you if you're at high risk because you've got pre-existing conditions. And some countries, like for example, India, are not offering the vaccine to pregnant people at all, no matter how high risk you're at. Okay, so these countries, I went off on a little bit of a tangent about India there, but these countries like the US and the UK and Europe, where the vaccines are being offered to pregnant people, we have a little bit of a problem because they haven't been trialed in pregnant people. So we have to give some thought to how we're going to ensure the safety and efficacy in this population. And I'll talk about that in a bit. But first, I want to tell you a bit about how I got into this area as an early pregnancy immunologist who mainly works on placentation. Well, it happened because last December, I started to notice rumours circulating on social media that the vaccines were going to cause sterility. And these rumours are still circulating. In fact, these posts that I'm showing you here are just ones that I pulled up, one day a couple of weeks ago when I was putting these slides together. And it got to the point where in the UK, we were seeing about a quarter of young women saying that they wouldn't have the vaccine because they were worried that it would harm their fertility. And I looked into this and I was able to trace these rumours back to this blog post, which was quickly taken down. But even so, this screenshot, minus the misinformation banner, which I've put here just in case anyone accidentally screenshots this screenshot was circulated on WhatsApp really widely. And I think it's important to note that the headline was very misleading because the person who made these claims was an ex-employee of Pfizer, but he was not, as was suggested, the current head of research. He hadn't worked there for a decade. And by the time that this happened, he was pretty prominent in the UK COVID skeptic community. So that's the place that he was coming from. Also, actually, even he didn't actually claim that the vaccine was female sterilization, only that it might have the potential to reduce fertility in the short term. So this headline is actually what most people saw, but the actual claims that these two people made were that the spike protein of SARS-CoV-2, which is the protein that the virus uses to enter cells, is very similar to a protein in the placenta called syncytin-1, which is important for the formation of the placenta. And the vaccines work by raising an antibody to the spike protein. That's how they protect you from the real virus if you ever encounter it. So these two suggested that those antibodies that are raised by the vaccine against spike protein might therefore also bind to syncytin in the placenta. Now, immune responses to the placenta is really my whole research area. So when I saw these claims, I thought, wow, I'd really better understand these claims a lot better. So I took a look at the region of concern, and here it is in this red box. The top sequence here is spike. It's the amino acid sequence. For any non-scientists joining us, amino acids are kind of like beads on a string, and then the protein folds up into its 3D shape. So we've got a kind of string of beads folded into a 3D shape. And he's basically identified here 5 beads, 5 amino acids that match between spike at the top and syncytin-1 at the bottom. So we've got this region of homology of 4 amino acids, which is actually broken in the middle by an asparagine to leucine substitution. And asparagine and leucine aren't even particularly similar, completely different colors of beads. So straight away, we're thinking, oh, well, these are not that similar. But of course, antibodies recognize proteins in their native conformation, their natural shape. So are the two proteins structurally similar? Well, no. So from first principles, we would say that there's no theoretical basis for this claim. And we would also point out that if antibodies against spike protein raised by the vaccine cause miscarriages, we might also expect antibodies raised by natural infection to cause miscarriage, which I've already mentioned that we don't. So for all of these reasons, this really didn't seem like a very believable claim. But nonetheless, and more to put people's minds at rest than because they believe this claim, Alice Liu-Culligan in Akiko Iwasaki's lab took convalescent serum from people who had recovered from COVID, and that's going to contain anti-spike antibodies. And she looked to see if the antibodies in this serum would bind to syncytin-1, and they didn't. Now, this is data that they talk about in this really nice New York Times article, although that's now, a couple of months old. And I know that they're writing up the study formally now, but it's not out yet. So I can't show you the beautiful blank gel that shows that there's no binding between these proteins. Okay, so the specific claims are quite firmly laid to rest. But nonetheless, we now have a situation where, without knowing quite why, lots of people are very worried that the vaccine is going to impact their fertility. And I've told you all of this so that in your own conversations with people who've got these worries, or maybe you're a person even who has these worries, you know the background to where these ideas came from. But what I found in my conversations with people who have these worries is that debunking the specific claims about anti-spike antibodies binding to syncytin-1 doesn't really speak directly to these people's concerns. Because for them, the question is really, does the vaccine affect fertility by any mechanism? They don't care what the mechanism is. And luckily, we do have data to address these concerns. So the first thing to say is that all of the approved vaccines, and I'm including AstraZeneca here because we've approved that in the UK, all of these vaccines, and I'm including Johnson & Johnson here because that was approved in the USA when I put these slides together. We may come back to that in the Q&A. These have been tested in animals, and they do not harm fertility or pregnancy in animals. But I think that the strongest evidence that there's no harmful impact on fertility comes from the clinical trials themselves. Now, pregnant people were not recruited to the trials and participants were asked not to become pregnant, but accidents happen, and nonetheless, across all 4 of these trials, there were 65 unintended pregnancies. And these occurred equally across the vaccinated and the unvaccinated groups. And also things like miscarriages occurred equally across both groups. So to me, that's very strong evidence that the vaccines are not preventing people from getting pregnant. And they're also not causing problems in early pregnancy if they're given at around the time of conception. And if you would like to look this data up for yourself, I'm taking the animal data and the numbers that I'm showing you here from the FDA briefing documents for the Pfizer, Moderna and Janssen vaccines, and for the from the MHRA emergency use approval for AstraZeneca. Finally, it's worth also mentioning that now a lot of people who have had the vaccines in general rollout have subsequently become pregnant. And in the UK for a little while, people were reporting their pregnancies to our adverse events reporting system, Yellow Card, which meant that we had an official record of this. Although, of course, most people will not consider a wanted pregnancy to be an adverse event. So these are going to be underreports. But at some point, Yellow Card started removing this data, maybe because they think that a wanted pregnancy is not an adverse event, or maybe because, having investigated, they think that it was not the vaccine that caused the pregnancies. So now we can see the pregnancy data, but it's usually only the data for any given week. And that's usually actually about 5 people, which, as I said, is an underreport. So this question about fertility is how I started doing work in this area. But then very naturally, people started asking, well, I'm actually pregnant already. Is it safe for me to have the vaccine? And at the beginning, the answer to this for both the mRNA, so that's Moderna and Pfizer, and the single cycle adenoviruses, adenovirus vaccine, vector vaccines, so that's AstraZeneca and Johnson & Johnson, was, well, theoretically, yes. There's no reason to believe that they won't be based on how they work. And from that handful of people who got pregnant in the trials, we also expect them to be safe. But we haven't formally trialed the vaccines in pregnant people, so it's hard to make as strong a recommendation as we would like. But given the risks to pregnant people and their babies that I've just outlined, the USA, the UK and the EU decided to offer them the vaccine anyway, with slightly different conditions, as I've explained. And because the USA has been the most sort of keen, I guess, to offer the vaccine to pregnant people, we end up with most of our data coming from the USA. And so I'm going to focus now on 2 data sets from the US. And that's partly because, as I've said, your data set is the biggest, nearly 78,000 pregnant people vaccinated by the 4th of April. And also that's because there is active tracking data that has been published in the USA, whereas in Europe, we do have some active tracking studies, but those have not been published yet. So, as the vaccines were rolled out, adverse events in the USA were tracked through VAERS, which I always call VERS. I don't know if anyone else calls it VERS, but I'm going to call it VERS for the rest of this talk. And the UK equivalent is Yellow Card, and in the EU we have Vigilance. And the idea here is that if something happens to you after you're vaccinated, whether you're pregnant or not, you report it to VERS. And if VERS gets more reports than it would expect by chance, that's a safety signal, and it would be investigated, and possibly we would change, well, whether we're offering the vaccine at all, or maybe who we're offering the vaccine to. And today, I see that you've got a safety signal in the USA emerging in the context of the Johnson & Johnson vaccine, or the Janssen vaccine. And for that reason, the FDA has decided to withdraw it for the time being. So that is an example of a safety signal appearing in the data set and the government taking action. In the UK, we've seen a similar safety signal emerging with the AstraZeneca vaccine. And we have taken a slightly different view, which is that the risks are still The risk-benefit balance falls in favour still of taking the vaccine if you're over 30, but if you're under 30, you should be offered an alternative. So these are examples of us spotting safety signals in the vaccine data and changing our policies as a result of them. So what happens when we look at these this safety data specifically in pregnant people? Well, here it is up to the 4th of April, which is the last point at which it's published. So you can see that among 78,000 pregnant people vaccinated, there have been reports of, well, mostly actually reports of sort of common side effects that everyone gets, like fevers and headaches and fatigue. But also, in terms of pregnancy-specific reports, 60 miscarriages, 15 preterm births, excluding cases of preeclampsia, 4 cases of preeclampsia, and it actually doesn't show up on the chart because there are now too few of them compared to the various other things, but there have also been 3 stillbirths. Now, taking the data at face value, those rates are incredibly low. So the first thing to say is that we are not getting a safety signal on any of those. And by the way, the UK yellow card data shows the same. But I do mean it when I say that they're incredibly low. That's to say these rates are actually much lower than we would usually see at sea. And that seems unlikely. And the reason for this is that this is a passive surveillance system. So a lot of events simply won't get reported, either because people don't know about the system, or maybe they do know, but they think that the event that they've experienced would have happened anyway, so they decide not to report it. And we can tackle these problems by instead using active surveillance. That's to say, after giving people the vaccine, we regularly check in with them and we specifically ask them if they've experienced any particular event. And in the USA, you're doing this through a program called VSafe. In the UK, we have a few different active tracking systems, but none of them have been really as well publicised or as widely used as VSafe. Also, none of them have published any data yet. So really, VSafe is just currently the best data set to look at this. And looking specifically at pregnant people, at the moment, there are 4,218 enrolled. But at the time of the last report, which was back at the beginning of March, there were only 1,815. And if we look at the report from the beginning of March, which reported on data in the middle of February, because there's always a bit of a lag in terms of collecting it and analysing it, we can see that the rates of all of these various complications of pregnancy are higher than we saw in the FERS data, which is what we expect because we've been soliciting reports rather than waiting for people to come forward. But they're still in line with what we see in the unvaccinated population, which again is good evidence that there are no pregnancy-specific harms associated with these vaccines. And it's worth mentioning that in the USA and Israel, there's also a surveillance of adverse effects that happens by pulling records from people's healthcare insurance providers. And we have a project in the UK called Open Safely, which does the same with our NHS records. So there's another layer of vigilance that's going on there. Finally, there are formal clinical trials underway in pregnant people. One is for the Pfizer vaccine and one planned for the Janssen vaccine. And these are important for 2 reasons. First, to assess safety, specifically in this population. But also, I already mentioned to you that the immune system works a bit differently in pregnancy. So it's important to assess efficacy separately in this population. Although, to be clear, we know that Tdap and flu vaccines work just as well in pregnant as in non-pregnant people. So we probably expect these to work just as well in pregnant people. But still, it's important to check. And just last week, some data that partially addressed this question did come out. It looked in detail at antibody responses to vaccination in 84 pregnant and 31 breastfeeding people who had had either the Pfizer or the Moderna vaccine, compared to the responses, the antibody responses they were looking at specifically here, in 16 age-matched controls. And interestingly, the pregnant and the breastfeeding people did, after 1 dose, make a slightly less good antibody response for many kinds of measures than the non-pregnant, non-breastfeeding people. But after 2 doses, the pregnant and the breastfeeding people caught up. So it was the same. And this was quite interesting to me because I mentioned already that flu and Tdap vaccines work just as well in pregnancy as they do in non-pregnant people. So I had kind of expected that for COVID too. But the authors of this paper make a very good point, which is that for almost everyone, flu and Tdap will be boosters, or perhaps in the case of flu, it will effectively be a booster because maybe you've never had a vaccine before, but you might have had the natural disease. So for Tdap and flu, it's like you're getting dose 2. And maybe that's why they work equally well in pregnancy as in non-pregnancy, whereas in COVID, we see this slightly less good response to the first vaccine. But before we leave this discussion of the risks and benefits of vaccination in pregnancy, I do just want to mention one more thing, which is fever as a side effect of vaccination. Now, fever is quite commonly self-reported, although most of these are going to be mild to moderate fevers. But the reason that it's worth noticing is because we have epidemiological evidence that high fevers in a short window in the first trimester can be associated with increased risk of birth defects. To be clear, we see this when people have a fever of more than 39 degrees C, which is 102 Fahrenheit, for more than 24 hours. And most people in the context of vaccination or even in natural infection will get nowhere near that. But still, to be cautious on this matter, the American College of Obstetricians and Gynecologists recommends that anyone who gets fever as a side effect of vaccination during pregnancy brings down their fever with Tylenol, or what we in the UK would call paracetamol. Because we know from epidemiological studies that managing a fever this way in pregnancy brings the risk of birth defects back down to the baseline level. And we also know that paracetamol is safe in pregnancy and won't stop the vaccine from working. Some other jurisdictions are making different recommendations to tackle the same potential risk. So some are suggesting that people should wait until they're more than 12 weeks pregnant to have the vaccine. And I think that we can probably take the view that given, as we've discussed, that the risk of COVID is low in the first trimester, for most people, there'll be no harm in waiting till the second trimester to be vaccinated, if that's what their jurisdiction recommends, or if that's just what they feel comfortable with themselves. Well, we've considered potential harms of vaccination during pregnancy in quite some detail. And it's my view, having spent a lot of time with all these data, that on balance, these vaccines do all look pretty safe in pregnancy. And given the risks associated with catching COVID, I personally think that the vaccine should be offered to all pregnant people. That's a policy that many states, almost all the states in the USA, are following, as well as Israel. The body that makes the recommendations in the UK is still considering the matter. I think they're going to have to make a decision quite soon because now the vaccine is available to people who are aged between 45 and 50. So very soon we're going to be getting down into that age group that will have a lot of pregnant people in it. We'll see what view they come to. But before I finish, I just want to tell you some of the potential benefits of maternal vaccination for newborns. First, as we expect, IgG crosses the placenta. So when people get vaccinated, they raise a good IgG response, and the babies of these people will have anti-SARS-CoV-2 spike IgG in their blood. So this study looked at 122 pregnant people who received either the Pfizer or the Moderna vaccine. And then they looked at how the antibody response develops in the mothers. And you can see that gradually, if we're looking over on the left here, we go from no response in light grey to a response in the mothers, which is in sort of this mid-grey colour. And that happens over the course of a couple of weeks. But then from 3 to 6 weeks, we start to see antibodies in the babies too. That's the darker grey bars. Here are two other studies. The top one shows 9 mother-baby pairs, and the bottom one shows, I think, 20, which also show transfer of antibodies into the baby. These studies actually came out first, but I think they don't illustrate it as nicely as that first one that I showed. And finally, here's a case study showing this in just a single baby, but I include it because this was the first report of this back in January. And we might expect these antibodies to protect the baby. That's certainly what we see in the context of Tdap and flu vaccination. But in the context of COVID, we don't have the data to be sure of that yet. And finally, to complete the picture, We also see anti-spike IgG, IgA, and a little bit of IgM in breast milk following vaccination. Interestingly, actually, this same picture showed in a supplementary figure, and you can kind of see it here too if you squint at the difference between the filled circles and the open circles. The filled circles are Moderna, and the Moderna vaccine does seem to be putting more IgA into milk. The authors of this paper suggest that that might be because of the longer interday schedule for Moderna, but we don't really know if that's the case yet. Here is another study. This one's only on 6 breastfeeding people, and it showed the same effect on their milk. And again, based on what we know of other infectious diseases, we might expect these antibodies that are going into the milk and that are then coating the baby's mouth and gut and potentially also somewhat nose to provide some protection for the baby. But for COVID, we don't have the data to be sure of that yet. So to summarize, COVID-19 is bad in late pregnancy. Not as bad as flu, actually, but still, I would say definitely worth avoiding. Meanwhile, all the data that we have on the vaccines say that in terms of pregnancy-specific effects, they are safe. And it's for this reason that a lot of jurisdictions are now offering the COVID-19 vaccine to pregnant people. The vaccines also have the potential to offer the baby some protection. And if we're talking about fertility, which you may well end up doing since the misinformation on this is so widespread, then we have lots of evidence that the vaccines don't harm fertility. So all the studies that I've talked about today, and actually more, including one that came out this morning that I didn't even manage to put onto my slides, all of these studies, you will find them linked and discussed in this document, which I update regularly. And the easiest way to get a hold of this document is you'll find it pinned to the top of my Twitter profile. So please say hi if you stop by. Or there is this more formal document in Nature Reviews Immunology, but that one isn't regularly updated. So it's kind of frozen in time in late February. And this is quite a fast moving field. Definitely there are things that I was like, oh, we might expect the antibody to get into breast milk, I said in that document. And since then, 4 studies have shown that it does. Finally, I'd like to say that work in my lab is funded by the Royal Society, the Wellcome Trust, and the preterm birth charity Born. And I'm happy to take any of your questions.
Thank you, Vicky. That was a great talk and a great summary of all that we know until now about vaccines and pregnancy and lactation. Thank you. And let's get into questions right away. Stephanie, could you please unmute yourself and ask your question?
Yes, hi. Yes, can you hear me?
Yes, we can.
I actually have 2. So with that chart that compared, there was the background rate, I think it was called, and the rate of miscarriage over there was 25 or 26%. But when I had looked at the resource because I found that a bit alarming, and when I looked at the reference for the paper, I found it to be very old. So is this still valid right now? And like, is it a fair comparison between the vaccinated and the non-vaccinated group?
So you're asking, is the rate of miscarriage in pregnancy really 25%?
Yes.
And actually, the answer is yes, it is. And people find that surprising, perhaps for 2 reasons. Partly that although miscarriage is common, it's not something that people talk about a lot. And we can have a whole other discussion about whether we should, whether this should be a taboo or whether this is something we should talk about more. But the reason that, another reason that we see a really high rate is because it's to do with when you test for your pregnancy. So if you take one of these super early pregnancy tests that, says, oh, I'll give you a result 3 days before your period, this is when we see a 25% miscarriage rate. Because actually a lot of pregnancies will miscarry at the point that if you weren't really paying attention to it, you might go, oh, my period's a couple of days late. Oh no, now it's come. And if you hadn't done a pregnancy test, from your point of view, that would be a late period. But if you have done a pregnancy test, from your point of view, that's a miscarriage. So actually, this 25% rate comes from when we do very early pregnancy tests. By the time we get to sort of 6 weeks, the rate has fallen a lot, and it keeps on falling through the first trimester, which is why a lot of the time people will say, oh, don't tell your people that you're pregnant until 12 weeks.
Yeah.
Again, that comes back to this idea that we don't want to talk about miscarriages, because what that advice is really saying is don't tell people you're pregnant to 12 weeks in case you have a miscarriage. So that's where that 25% figure comes from. It is 25% across all pregnancies, but so many people won't even know that they're pregnant and have had a miscarriage if they haven't done one of these early pregnancy tests.
Okay. I actually have another question, but I think I'll leave the turn for someone else, and then maybe I'll ask some mine later if there's time.
Stephanie, why don't you go ahead? Since you're on, just
Okay.
continue. Yeah.
Okay, thank you. So my other question is, so this is a personal question. I'm actually 10 weeks pregnant.
Oh, congratulations.
Thank you very much. And I'm in a country, I'm in the UAE, where they will not, where vaccines are not allowed. And I'm actually considering lying and getting it. So I'm wondering what I think you touched on that, but I think I missed it. The best window safety-wise to get the vaccine, given that I also need to consider that, like, when I'm showing, I will not be able to get it. Sorry, I want to go into detail. Sorry.
That's a very interesting question that brings up a whole host of answers, and I can't really recommend people go against the medical advice in their own country, even though I might disagree with the medical advice in their country. And as I've mentioned, I actually disagree with the advice in my country, because I think the vaccine should be offered to all pregnant people like they're doing in the USA. But you've asked a question which I think I can tackle a little bit more generally, which is, when is the best time to get vaccinated during your pregnancy if you have the option? And the first thing to say is that this really big safety data set that we have from the USA suggests that there's no time when it's more safe or more dangerous. It seems to be, very safe whenever you choose to do it. However, some people do feel more comfortable waiting until after 12 weeks, because after 12 weeks is when all the organs are formed. And so there's more potential for things to go wrong before 12 weeks. This is just how people feel a bit more comfortable. As I mentioned, I don't think that there's any danger in waiting until after 12 weeks, because the most dangerous time is towards the end of pregnancy. So even if you do get vaccinated, kind of like in the second trimester, hopefully you'll still be protected by that period when you're more at risk. The other thing that people sometimes want to consider when they think about when in pregnancy would be good to get vaccinated is, when is the best time in terms of transferring my antibodies that I'm making into my baby? And the study that I showed you that kind of had the different colors of gray bars really kind of tackled that. And basically it says, well, if what you want to do is transfer antibodies to your baby, you don't want to leave it too late, because if you leave it too late, you haven't had the chance to transfer them across the placenta. So that study again would recommend that you would be kind of vaccinated somewhere in mid-pregnancy. But what I would say is that I consider any protection that the baby gets as a result of vaccination to be a bonus. Like, we're super happy to have it, but I don't think we should direct all of our goals towards protection for the baby. The most at risk person here is the mother. And of course, through the mother, the baby is at risk as well, because if the mother ends up, in intensive care, that's bad for the baby. If the mother gives birth early, that's bad for the baby. So I would say, prioritize your own safety. And if you are somewhere where the vaccine is being offered to you, then, I certainly, if I were pregnant, which I'm not right now, would feel comfortable getting it.
Hi, Vicky, if Stephanie has more questions, can she DM you on Twitter?
She absolutely can, and loads of people do, although I'm a little bit behind on my DMs at the moment. So if people are DMing me, you might have to wait a couple of days for me to get back.
Okay, good luck, Stephanie.
Thank you.
All right, Stefan, you had a question. Could you please unmute yourself?
Yeah, thanks. Thanks, Vicky. So in your talk, you said that COVID-19 is bad in pregnancy, but not as bad as the flu. do you mean that COVID-19 is less dangerous than the flu to pregnant women in absolute terms, or that its effects are less enhanced in pregnancy than those of the flu, while it's being more dangerous than the flu in absolute terms?
Yes, that's a really good point. And actually, you're correct to note that those, well, so first of all, you know, the data on flu is kind of a little bit squishy, because it's actually been collected over the course of 120 years. And the most, you know, striking flu is dangerous in pregnancy data actually came from the 1918 flu pandemic. But we did see the same thing, for example, in 2009. And that's what informed the UK's decision to start vaccinating pregnant people in 2010, which they hadn't bothered doing before, against flu. So yes, you're right that actually all of these comparisons are effects if you are pregnant versus effects versus if you're not pregnant. And we might say that actually COVID is worse than the flu. So, you know, a 2 times increased risk on something that's worse than the flu is still worse than a 5 times increased risk on the flu. So that's actually a really good point. But actually more than that, I guess the point that I want to make is that at the moment, you're really, really unlikely to catch the flu. Flu has been, certainly in the UK, like absolutely smashed to the floor by social distancing, whereas COVID is still a thing. So you're much more at risk of COVID at the moment, just because you're much more likely to catch it. So I think if we put all of these things into the pot, you know, it's difficult to make exact comparisons. But the reason that I mention this, I suppose, is a little bit UK specific, because there was a very specific piece of guidance from the JCVI, which is our council that decides who should get vaccines. And they said that the evidence was not in support of routine COVID vaccine during pregnancy. And that's why we're not offering it to everyone. We're only offering it to people at high risk. And from that, I read into it that they basically thought that, clearly they think that routine flu vaccination in pregnancy is worthwhile. And I think that this is the kind of data that's playing into that decision. They think that, you know, the additional risk in pregnancy is not as much as the additional risk in flu. And also, we're obviously in this situation where we have less safety data in pregnancy, and we don't have formal clinical trials in pregnancy, whereas we do in flu. We will shortly have formal clinical trials, but at the moment, we're making these decisions in a, you know, with slightly limited but ever increasing information.
Thanks so much.
Thanks, Vicky. Thanks, Stefan. Sophie, you had a question.
Hi, yes, it's actually just been touched on really, but it was about the JCVI in the UK and when whether you thought we might be moving to a position where vaccine is offered to all pregnant women in the UK, and whether you thought they might recommend particular vaccines where there is better evidence about effects.
So, yeah, I mean, obviously it's really difficult for me to speculate on what the JCVI are going to do. And having read the JCVI's interim report on the rollout, which came out at the end of February, they noted that, you know, so far there are no safety signals for either Pfizer or AstraZeneca, which were the only 2 that we were using at that time in pregnant populations. So they noted that. And they said that they were continuing to review the evidence. And I fully expected that at their next major review, they would make some kind of a statement. And I don't know what that statement's going to be. I really don't. But obviously, a lot more data has accumulated since on the 30th of December, they first said we're going to offer it to people at risk. And I think the accumulation of that data may well weigh in on their decision. So I can't really speculate about what that decision will be, except to say that, of course, all of a sudden the JCVI are very busy on this other matter of the AstraZeneca vaccine. So I don't know if that will somewhat take their attention away from, you know, from making this decision. But nonetheless, at their next report, I think they're going to have to say something, because we're getting to the point where we're just on an age basis offering the vaccine to people who might be pregnant but are not at high risk. So they're either going to have to say, yes, you can have it, or they're going to have to say, no, we're still recommending that you don't. And I don't think they can not say anything at their next report. I think they're going to have to say something. I know. Have I been infuriatingly unwilling to speculate? Until very recently, I would have speculated that they'd go for it, but I do just wonder if, you know, these recent safety signals we've seen with AstraZeneca may make them a little bit more cautious.
Thank you. Vicky, adding to that, would you like to say something more about VIPIT, the vaccine-induced prothrombotic immune thrombocytopenia? I hope I got that right.
Yes. So this has been, you know, the big issue in vaccine safety over the last couple of weeks, and in many ways it's been, you know, actually for people who worry about vaccine safety, it's in some ways been weirdly reassuring, because they have very quickly detected a safety signal turning up in the data. And so that tells us that, you know, these passive reporting systems are working as they're supposed to. But one question that has then come up, and so in the USA, I see that today you're pausing the rollout of the Johnson & Johnson vaccine because of VIPIT. Which you've seen at about a rate, I think, of kind of about 1 in a million, which is a little bit less than we've seen in Europe. It's kind of between 1 in 100,000 and 1 in a million in Europe. And so you're pausing that, you know, out of an abundance of caution. In the UK, certainly, we've taken a slightly different view with AstraZeneca, which is another vaccine that's on the adenovirus vector platform. Where we've also seen this vaccine-induced prothrombotic immune thrombocytopenia, or as we're going to call it for short, VIPIT. And what we've done is we've decided that looking at the risk right now in the UK of catching COVID, and the risk right now in the UK of not of catching COVID and having a bad outcome for COVID, like going to intensive care, basically, compared to the risk right now in the UK of having a VIPIT event following AstraZeneca vaccine. And basically in the UK now, COVID is quite low because we're just coming out of our third lockdown. And with quite a low rate of COVID, it means that in young people, it's more likely, and when I say young, I mean under 30, it's more likely to be a bad effect for you with the AstraZeneca vaccine. So for those people, they should be offered an alternative. So that's the policy here in the UK. We haven't stopped it completely. But we have noted that if COVID rises again, then the risk to under 30s of COVID goes up, whereas the risk of the vaccination stays the same. And at that point, it's possible that we may say, well, young people, now it's worth your while getting AstraZeneca. It would be better for you to take the chance of a problem with that than the chance of catching COVID and having a problem with COVID. In terms of the stuff that I'm interested in, one question that a lot of people have asked me is, how does this intersect with the advice about vaccination that is given to pregnant people? Because pregnant people are already at higher risk of clotting. But I think it's actually worth noticing that VIPIT is not just clotting. VIPIT is a really interesting constellation of symptoms, which includes thrombosis, which we might call clotting colloquially, but also thrombocytopenia, which means a lack of platelets. And it really looks actually a lot like something called heparin-induced thrombocytopenia, which is a sort of rare immune reaction that some people get to the anticoagulant heparin. And actually, this is rarer in pregnant people. So I think that the fact that pregnant people are more likely to suffer clotting in general doesn't necessarily mean that they're more likely to suffer from VIPIT. So this is my opinion. And the JCVI and the Royal College of Obstetricians and Gynecologists sat down together and had a meeting last Friday. And they released a statement, which my reading of it is, it says something similar to what I'm thinking, but it was couched very, very cautiously. So it was quite difficult to work out what they were actually saying. But I think that between the JCVI and Royal College of Obs and Gynae in the UK, they're basically saying, work out whether you should or shouldn't have it based on your age risk, the same as everyone else. We're not going to make a different recommendation for pregnant people.
Excellent. Stephanie, please unmute yourself and ask.
Yes, it's me again. So
Hi.
the thing you called the VERS, I think, is that available for the public? And
Yes,
would you mind
it
sharing the link maybe on
absolutely
the
is. I'll tell you what. Yes, I will. DM me and I will send you the link. And what I love about VERS, which I didn't say, but what I do really love about VERS is you access the actual reports. So in the UK, we get a weekly summary and it'll just say something, that someone will already have binned the data together. And it'll just say something like miscarriages, and you won't know if they were early or if they were late or what. VERS, you actually read people's actual detailed reports. So you get so much more information from it. It's incredibly granular. But what I also love about VERS is that some of the reports are really sweet. So some of the reports are just say things sort of like, I read one report that said, I'm pregnant and I don't think this is anything to do with the vaccine, but I got an ulcer after I had the vaccine, so I thought I'd tell you about it. Or one that said, I'm putting in a report, not because anything bad happened, but because the lady then went on to have a baby and it was all fine. And so when I summarize my adverse events reports, I remove those ones that, well, actually, no, I left in the ulcers, but ones where people are just like, and later on the lady had a baby at 38 weeks. I'm sort of an expected outcome, don't we think? So there are some really sweet ones in there, which I quite enjoy reading.
All right, thank you very much.
Vicky, thank you so much for your time and your efforts, and particularly for making yourself so available.
I think it's really important actually at this point that people are dealing with information rather than misinformation.
Yeah.
And I completely get that actually decisions about this in pregnancy are really difficult and complicated, although a lot of people are struggling with them. But I think the message actually about fertility is really important, because it would be sad, wouldn't it, for people to decide not to take a vaccine that could, improve their health and the health of their loved ones, because of course this is transmissible, because they read something that was actually not true. And so I think that, this is why it's really, really important to be talking about this right now.
Yeah, no, this is spectacular. What a public service.
Thank you.
Thank you.
Yeah. Thank you. And so everyone, DM Vicky with all your questions.
I'm going to be inundated.
Okay. Thanks, Vicky.